Dear colleagues, good evening, good afternoon, good night, good morning. A warm welcome to you all on this webinar on central serous chorioretinopathy organized by Euretina. My name is Camiel Boon and I'm an ophthalmologist in the Amsterdam University Medical Centers and Leiden University Medical Center in the Netherlands. We've got many attendees, which is great, and it also reflects the need for more information on this mysterious disease. Central serous chorioretinopathy is still surrounded by controversy and uncertainty. For instance, with regard to its pathogenesis, but also even its diagnosis, differential diagnosis, and certainly also the treatment. Unfortunately, there are some recent insights that really help us to grasp these aspects of the disease a bit better to use it in our clinical practice. And I'm happy and honored that we have a list of experts in this field willing to contribute to this webinar. We've got 5 presentations that will cover these different aspects. The talks will be relatively short to be able to reserve as much time as possible to discuss your questions and potential topics. And I would like to ask you to please send your questions via the chat. And because of the large number of attendees, we may not be able to address all the questions orally, but we'll try our best to answer as many of them as possible if needed via the chat. So without further ado, I would like to start with the first speaker, Dr. Sekar Galuh from Indonesia and the Netherlands, who's going to tell us about the new evidence on the pathogenesis of central serous chorioretinopathy. Thank you.
Dear colleagues and chairmen, ladies and gentlemen, first of all, I'd like to thank you for the opportunity to contribute to this Euretina educational webinar. And today, I'd like to share some experimental evidence on the pathogenesis of central serous chorioretinopathy, or CSC, including the studies that we conducted in our lab. I have no financial disclosure. Central serous chorioretinopathy, or CSC, is a common chorioretinal disease. Multimodal imaging, including ICGA or indocyanine green angiography, is mandatory to establish the diagnosis. On OCT, subretinal fluid and usually a thickened choroid can be observed. On ICGA, imaging the choroid, CSC is characterized by hyperfluorescent area indicative of the thickened and hyperpermeable choroid. The risk of CSC is increased because of 2 important risk factors. First, male predisposition. Males are 6 times more likely to develop CSC than females, which indicates that sex hormones may play a role. The second risk factor is exogenous corticosteroids use, and this is the most pronounced risk factor of CSC. This is interesting because the increased risk of CSC by corticosteroids is independent from the route of administrations and dosage. Corticosteroids act in a cellular level. To deliver a response, corticosteroids such as cortisol, aldosterone, and dexamethasone will bind to receptors, either mineralocorticoid receptor or glucocorticoid receptor, depending on their binding affinity. It still remains a question how these receptors are regulated in CSC. However, in general, for example, glucocorticoid receptor or GR, cortisol will bind to the receptor in cytoplasm, and once they form a complex, they will translocate to the nucleus. The complex will bind to GRE or glucocorticoid response elements and generate transactivation or transrepression. So now, what is the current experimental research evidence? There are still quite some unknowns to questions, but we certainly have some clues. In the next slides, I will discuss with you some interesting related evidence. To identify the underlying mechanism and get closer to human condition, we isolated and cultured human choroidal endothelial cells that we obtained from post-mortem donor eyes. The specific procedure allows us to assess the cortisol response and, for example, the role of different receptors to which corticosteroids bind. This picture shows the complex layer of retinal pigment epithelium, which lies above the choroid and the choroidal layer. In our experiments, we found that the glucocorticoid receptor, shown in the green label on the left image, is expressed in the human choroidal endothelial cells. In contrast, the right image shows that mineralocorticoid receptor is scarce and only expressed within the neuroretina, which is not shown here. These immunofluorescence results exactly reflect our in vitro cortisol response and the Fiji clinical trials, in which eplerenone treatment has similar results as the placebo treatment in treating central serous chorioretinopathy. The Fiji randomized controlled trial clearly show that there is no effect of oral eplerenone as the antagonist of mineralocorticoid receptor, or MR, in the treatment of chronic CSC. These all findings then indicated that MR, or mineralocorticoid receptor, is not the main target of treatment in patients with chronic CSC. However, some studies have found that MR is found to be involved in CSC pathogenesis as identified in a study using rat model. Aligned with that, in human we also found that the gene variant of NR3C2, a gene that encodes MR, is associated with an increased risk of chronic CSC. Moreover, we evaluated the genome-wide expression upon cortisol exposure. We cultured choroidal endothelial cells from healthy donors and treated them with cortisol. On the right side, as you see, that all genes are almost perfectly aligned to the diagonal between males on the y-axis and females on the x-axis. This means that males and females had a very similar cortisol response. It also indicates that there is no intrinsic gene difference between male and CSC females. Remarkably, there is this ZPTP16 gene, which is highly upregulated in both sexes, and currently we are working on the functional implication of this gene. Besides an intrinsic gene response, the functional properties of choroidal endothelial cells are also interesting to observe. There is clear phenotype change as dilated and thickened choroidal vessels are seen in CSC. The main question is how can we recapitulate this phenotype on the experimental model? The hyperproducent leakage we see on ICGA of CSC patient has been thought to indicate choroidal vascular hyperpermeability. In principle, we can measure the function of endothelial cells barrier using an automated machine. It will tell us on how good the barrier integrity actually is. Moreover, it can estimate the permeability or how well the molecule transfer from one site to another. However, the fluid accumulation that occurs in CSC cannot be recapitulated in this setup, for which a dynamic fluid and three-dimensional model will be required. We are currently developing such an experimental model which will provide additional answer in explaining the pathogenesis of CSC. Some messages to take home. First, laboratory studies show CSC may be associated with the glucocorticoid receptor, or GR. Second, there seems no intrinsic sex difference in cortisol response of choroidal endothelial cells from males and females with CSC. And the third, a suitable experimental model is required to recapitulate the subretinal fluid accumulation that occurs in CSC. I would like to thank my colleagues and thank you very much for your attention. I will be, of course, willing to answer your questions during the discussion sections at the end of this course.
Wow, Sekar, thank you very much. I'm sure that has raised many questions. It's my pleasure now to introduce the next speaker, Professor Gemmy Cheung. I don't think she's here right now, but she's a professor in Singapore, and she did some really tremendous, impressive work on the pachychoroid disease spectrum, including central serous chorioretinopathy and myopia. Thank you.
Thank you for the invitation to participate in this webinar on CSC. I'm going to focus on the choroid and discuss some of the pathogenic mechanisms. Increased thickness in the choroid has long been described, and these are believed to represent dilated Haller's layer vessels. With PDT, we appreciate that it can also lead to a reduction in the choroidal thickness. Using SWAPS also CT, we can appreciate the heterogeneity of the content of the choroid even better than SDOCT due to the increased signal-to-noise ratio. For example, in this comparison of SDOCT at the top and SSOCT at the bottom, note this area, which appears to be separate from the choroidal vasculature. This actually represents suprachoroidal effusion, something that is common in eyes with choroidal thickness beyond 400 micron and may represent a saturation of transscleral fluid movement. Looking at this other area, there appears to be a polygonal shaped area with hyporeflectivity. This is believed to represent caverns and may not always be a dilated choroidal vessel lumen. Correlation with histopathologic findings suggests that this is a lipid globule deposition. Using a software algorithm, we can also binarize these images so that the dark pixels represent lumen and the bright pixels represent stroma, and calculate a choroidal vascularity index. Moving away from structural cross-sectional OCT to en face images, here with a web source en face OCT, we appreciate that the dilated vessel crosses the macular area. In this example, the ICG is on the left, the en face OCT is in the middle, showing very good correlation between the two modalities. Again, the dark polygonal structures represent caverns in the choroidal stroma. And using a fly-through, we can appreciate first the PD and the choriocapillaris, and then the large choroidal veins coming into sight. And note that the en face image changes depending on the segmentation and depth that is used to generate the image. With ICGA, of course, we appreciate dilated veins and anastomosis similar to en face images, but ICGA has the additional advantage of looking at the hemodynamic filling. So in the very early phase, in this example, we also appreciate there is patchy and uneven filling with some areas being delayed. Using the movie in this area, there is a back and forth reflux-like movement or pulsation within a segment of the large choroidal vein. And going to the mid to late phase, we appreciate areas of hyperpermeability suggestive of choriocapillaris ischemia. Looking at the ICG beyond the posterior pole with wide field imaging, we can appreciate and see all the way to the vortex vein ampulla. In this example, we appreciate that the macular dilated vein actually connects to adjacent vortex vein system, which has led to the proposal of intervortex anastomosis. In this other example of wide field ICG, we observe that there is an unbalance between the distribution of flow with the infratemporal quadrant being predominant. Now, putting together all these imaging findings into theory, first and foremost, the venous outflow obstruction has been proposed by Dr. Spade for over a year now. We seem to follow this quite well. The focus of the abnormality seems to come from where the vortex vein exits the eye through the sclera. In eyes with short axial length, they tend to have thicker or stiffer sclera, and this may impose obstruction on the outflow. This leads to back pressure being transmitted through the whole choroidal venous system, leading to opening of pre-existing channels in the macula and formation of macular anastomosis between intervortex systems. Corroborating this theory is a very important body of work studying the scleral thickness by Professor Koizumi. Now, this looks at very anteriorly where the sclera sits, and it would be really nice if in future we are able to look at the posterior pole scleral properties as well. An additional theory that has been recently put forth is an unbalance between the distribution of flow within the vortex system. Previously, I showed you an example in which one quadrant predominates. In this example, in panel A, you can see the infranasal quadrant doesn't seem to drain very much and has been coined to be hypoplastic. So an additional theory to venous outflow obstruction is a congenital variation in the distribution or unbalance in vortex vein arrangement. So far, we've focused mainly on vein-to-vein abnormalities, but we know that the choriocapillaris ischemia exists, and this may occur either secondarily or as a primary event. And in fact, Professor Camiel Boon, our chair for this session, has proposed also to look at artery-to-vein abnormalities, and that I agree is going to be a very important area. Unfortunately, our current imaging modalities are not very good at differentiating artery from vein in the choroid. But for example, I'd like to show you this dynamic ICG in which we also see pulsatility, but we appreciate the characteristics is different from the previous example. Here we see small areas of blinking-like pulsation, which appear to affect smaller caliber vessels, as opposed to the back and forth reflux-like motion in the previous example, which was focused in a large choroidal vessel. Now, whether this represents more of an arterial involvement remains to be seen. So with that, I'd like to conclude that we've seen a very exciting array of imaging findings describing choroidal alterations beyond just an increase in thickness. These suggest a level of venous congestion, vein-to-vein anastomosis, and outflow obstruction is at least one of the lead theory proposed to contribute to the pathogenesis of CSC. Yet the primary inciting event remains unclear, and I think further work is needed to understand additional mechanisms. Thank you very much for allowing me to share.
Thank you very much, Dr. Gemmy Cheung. That was really a wonderful presentation. So for the next presentations, I would like to introduce Elon van Dijk. He's an ophthalmologist based in Leiden University Medical Centers, and he's also doing a research in central serous chorioretinopathy and retinal disease.
Ladies and gentlemen, I would like to thank both the organizer of this course, Professor Boon, and Euretina for the invitation to give a talk on the diagnosis of central serous chorioretinopathy. I have no conflicts of interest. Central serous chorioretinopathy, or CSC patients, can present with a wide range of visual complaints, such as blurred vision, metamorphopsia, loss of color vision, and loss of contrast vision. On fundoscopy, subretinal fluid can be seen, which usually presents foveally. However, the differential diagnosis of CSC is very, very broad. After fundoscopy, the next step to make the CSC diagnosis is obviously an OCT scan. This scan reveals the subretinal fluid accumulation. In most patients, a thickened choroid is present, which is another key feature of CSC. Pigment epithelium detachments are present in the majority of patients. Then contrast images are needed, at least in patients with persistent subretinal fluid. As the origin of CSC has been hypothesized to be choroidal, a combination of fluorescein angiography and indocyanine green angiography is required. A hotspot of leakage on FA is typical for CSC, revealing leakage through the retinal pigment epithelium outer retinal barrier, whereas ICGA usually reveals hyperfluorescent changes. These changes on ICGA are often more widespread compared to FA abnormalities. To provide patients information on the prognosis and treatment options, a division should be made between acute CSC, chronic CSC, and complicated CSC. However, this classification is controversial and variable. The International CSC Classification Consortium is currently working on this topic. Acute CSC is defined as an acute onset, dome-shaped serous detachment of the neuroretina, in which the subretinal fluid usually completely resolves in 3 to 6 months, together with a good visual prognosis. Smokestack leakage on FA is characteristic of acute CSC. In chronic CSC, some patients have a single leak on FA, whereas other patients develop extensive RPE disease, sometimes with terrible atrophy, scarring, and intraretinal fluid. In this patient with chronic CSC, it is clearly visible that abnormalities on ICGA are far more widespread compared to FA. CSC may be complicated by a choroidal neovascularization. In this patient, subretinal fluid can be seen, together with a flat RPE detachment. There is leakage on FA and there are hyperfluorescent changes on ICGA, characteristic of CSC. However, it is not clear if there is a choroidal neovascularization. In this patient, OCT angiography is very helpful, and it shows a choroidal neovascularization. Addressing risk factors of CSC is an important topic when establishing its diagnosis. CSC usually occurs in male patients between the age of 30 and 60 years. When the disease presents at an older age, this could be indicative of the presence of a choroidal neovascularization. Several genes have recently been identified to lead to only a slightly increased or decreased risk to develop CSC. It is therefore important to inform CSC patients about the fact that their male children only have a slightly increased risk to develop the chorioretinal disease. However, the most important of all clinical risk factors of CSC is hypercortisolism. The chance of developing CSC is up to 37 times increased in patients that use exogenous steroids and has been described to be independent of the dosage and the mode of administration of medication. Exogenous steroid use has been mentioned in as much as 52% of CSC patients. If possible, CSC patients should therefore definitely discontinue steroid medication. Endogenous hypercortisolism or Cushing syndrome, which is the abundant presence of the steroid-like hormone cortisol, has also been associated with CSC. A full-blown textbook Cushing syndrome has typical clinical features and is easy to diagnose. These patients are overweight with a moon face, striae and fat pads. Their skin bruises easily and has a decreased thickness. Patients with Cushing syndrome are often diagnosed with diabetes mellitus, hirsutism and hypertension too. However, it is a challenge to diagnose a subclinical Cushing syndrome. We have published that CSC can be the first manifestation of a Cushing syndrome without the presence of other clinical features typical of this syndrome. This graph shows passport photographs of 3 patients over time, on which the subtle occurrence of a moon face can be seen. Moreover, retrospectively, patients had several other complaints that could be typical of Cushing syndrome. However, only after the referral from the ophthalmologist to the Department of Internal Medicine, the diagnosis Cushing syndrome could be established. Ophthalmologists should therefore be aware of the presence of possible symptoms of Cushing syndrome in their CSC patients. To conclude, to diagnose CSC, you should never forget fundoscopy, also having a look at the peripheral retina to detect possible diagnosis that could induce fluid leakage. Moreover, multimodal imaging is essential and includes OCT, FA, ICGA, and OCTA. It is important to pay attention to the possible presence of both exogenous and endogenous hypercortisolism in these patients, as this is the most important risk factor to develop CSC. I would like to thank you for your attention and would be happy to answer your questions.
So after this presentation, we will move forward. The next presenter will be Suzanne Yzer, ophthalmologist from Radboud University Medical Center in Nijmegen, the Netherlands, specialized in medical retina, and she will talk about the very, very, very broad differential diagnosis of central serous chorioretinopathy.
Hello everyone, my name is Suzanne Yzer and I'll be talking about the differential diagnosis of CSC. I would like to start by thanking Euretina and especially Brendan Cheung and Camiel Boon for the kind invitation to be a speaker at this wonderful webinar. I have no disclosures. As we just heard from Elon van Dijk, when we talk about the differential diagnosis of CSC, we look for the presence of subretinal fluid and some specific changes in the choroid, as well as FA and ICGA characteristics. However, when some of these don't quite fit your diagnosis of CSC, you have to look further. We use multimodal imaging and, for instance, look for certain OCT signs or some retinal changes, ask for symptoms, and just by talking to your patient, you may actually be guided to the correct diagnosis. And of course, the correct diagnosis is very important and it may warrant unnecessary treatment, and you may actually save a life. The differential diagnosis of CSC is very long and I cannot go over every single one of them, but I'll give you an example of everything listed here. The first case is a 23-year-old healthy male who was seen because of family history of glaucoma. There was subretinal fluid present and the choroid looks more or less normal. Multimodal imaging was applied, however, this wasn't necessary because just by doing fundoscopy, the diagnosis of torpedo maculopathy was already visible. The next case is a 9-year-old girl. She was treated at the pediatric department with occlusion therapy because of her low vision in the right eye. At one point, an OCT was made, and there was subretinal fluid seen. The choroid, however, is pretty thin, although this is normal for her degree of myopia. An FA was made, but not much is going on here. However, when you look at the vertical scan, you may appreciate the inward bulge of the sclera, and this is a dome-shaped macula. The next case is a 25-year-old healthy male who came in because of an acute drop in vision in the left eye. The subretinal fluid was noted, and indeed he has a more or less focal thickness of the choroid underlying the subretinal fluid. He was referred to me. By the time I saw him, subretinal fluid had completely disappeared, and this of course fits the diagnosis of CSC. However, when I spoke to the patient, he mentioned that at the time when subretinal fluid was present, he also was experiencing a lot of pain in the eye, and he had to use ibuprofen to get through this period. So this is an example of posterior scleritis. The next case is a 51-year-old male who was seen in 2012 because of an acute CSC in the left eye. He was treated with PDT and it nicely dried up. And he was doing well until 6 years later, when he returned again with subretinal fluid. Multimodal imaging was applied, and here at the bottom you can see the ICGA. This is actually done with a regular fundus camera, so not SLO. And there's a plaque visible in the late phase. When we take a closer look at the OCT, you may appreciate the splitting of Bruch's membrane and the RPE, and this is called a double layer sign. And this is what we see in type 1 macular neovascularization, and in this case it's secondary to CSC in the past. Pachychoroid-related neovasculopathy is a type 1 macular neovascularization, and it can occur with and without aneurysms. It is usually seen in patients that have characteristics of pachychoroid-related disease, and it's seen in absence of drusen, and usually at a younger age if you compare to age-related macular degeneration. On OCT, double layer sign, heterogeneously hyperreflective material in the sub-RPE space and small peaked PEDs are visible. The next case is a 29-year-old healthy male. He was observed because of this subretinal fluid, and he was diagnosed with CSC. And indeed, there is a focal, very thick choroid present there. An FA was made, and there may be a small smokestack visible here. However, the ICGA, and again this is with a regular fundus camera, shows washout in the late phase. And this is compatible with a choroidal hemangioma. The next case is a 77-year-old male who was referred because of CSC in the left eye. Here are the images of both eyes, and you can see that it's pretty symmetrical, and especially if you look at the FAF shown at the bottom, you see the symmetrical roundish change visible. And when talking to this patient, I mentioned that I thought that there may be a genetic cause for the presence of a subretinal fluid. And the patient actually asked me if it could be Best's disease, because both his mom and his son were suffering from Best's disease. Moving on to systemic causes of subretinal fluid. Here's an example of a 43-year-old female, and she was seen because of loss of vision in the right eye. Fundoscopy and additional imaging of both eyes showed again that it's very symmetrical, and there's podorange visible, and also the angioid streaks. And this is an example of pseudoxanthoma elasticum. These patients need to be referred to a cardiologist or a specialized center and by doing so, you may save a patient's life. The next case is a 64-year-old male, and this is actually a patient from one of the papers from Elon van Dijk. He was treated for a metastatic cutaneous melanoma. Subretinal fluid there, choroid looks pretty normal, and this is an OCT of the fellow eye, and you can see areas of confluent subretinal fluid. And this patient was treated with MEK inhibitors. And this can cause a serous retinopathy, and this is usually transient, even upon continuation of the MEK inhibitors. The final case I want to show you is a 27-year-old female. She had sudden onset of nausea and vomiting, paresthesia in hands and face, pain in epigastrium, and acute drop in vision in the left eye. There's subretinal fluid, and you cannot really say anything about the choroid here. She was admitted to the neurology department, and she was actually too sick to undergo further ophthalmic examination. So we thought, this is a very, very sick patient with acute central serous in both eyes. She has hypertension, elevated liver enzymes, and thrombocytopenia. Could this actually be HELP syndrome? And this is what we mentioned to the neurologist, and they did some additional tests, and indeed it turned out that she was pregnant. Labor was induced, and she gave birth to a healthy little boy. And this is what her OCTs looked like a couple of weeks after delivery. She was doing well, and so was her son. So as I mentioned, in CSC you look for the presence of subretinal fluid and some specific characteristics in the choroid, NFA and ICGA characteristics. And if not all of these fit your diagnosis, you should think of other possibilities that can cause subretinal fluid. I've shown you some cases that may also cause subretinal fluid but are not CSC. But I've also shown you a case that is actually CSC. And by doing so, I hope that you realize that even a correct diagnosis of CSC can save a life, or even two. Thank you very much for your attention.
So moving on to our last speaker, who actually doesn't need an introduction, but he's the organizer of this wonderful webinar. It's Camiel Boon. He's a professor in ophthalmology in both Amsterdam and Leiden here in the Netherlands. And he's done some groundbreaking work on central serous chorioretinopathy. Camiel?
In 7 minutes, I would like to discuss evidence-based treatment of central serous chorioretinopathy with you. I do not have any financial conflicts to disclose. When we think about treatment of central serous chorioretinopathy, we should bear in mind that this is a disease that occurs at the interface of the choroid, Brooks membrane, RPE, and Euretina. In CSC, there is a disturbed equilibrium between the increased choroidal flow and permeability by a thickened choroid and the RPE pumping function that is compromised. Hence, there is a tendency to form RPE detachments with, in some cases, subsequent leaks of subretinal fluid. And this is what we want to reverse by treatment. Central serous chorioretinopathy is common, and it can lead to irreversible vision loss and a decreased vision-related quality of life. Hence, it would be good if we could treat CSC. But there is a highly variable preferred practice pattern around the world. And this controversy has been made worse because until recently there was no prospective randomized controlled trial available. But this has changed, and I would like to discuss them with you. You should bear in mind that CSC is a disease spectrum in itself, ranging from very focal, acute, self-limiting disease to focal chronic cases or severe extensive chronic cases with atrophy and cases complicated by CNV with or without a polypoidal component. First of all, you should really decide if it is really CSC. The differential diagnosis has so eloquently been discussed by Dr. Suzanne Yzer. If you want to read more about it, you can read this paper on serous maculopathy and the broad differential diagnostic spectrum. It is available open access, and you can reach it through the QR code in the lower right. We know that central serous chorioretinopathy is a retinopathy, of course, because of subretinal fluid and retinal dysfunction. We also know that this is the tip of the iceberg because the choroidal changes, as in this patient, are much more extensive, as you can see on ICGA, of the same patient, than the FFA changes depicted here on the right. And this is virtually always the case. So this means that we should aim to treat the choroid to really be effective in terms of the treatment in general. The aims of treatment and evaluation of efficacy are important, and I think it is very important to state that you would like to get rid of all the subretinal fluid and get rid of the leakage to improve vision, because only then there will be a reattachment of the neuroretina, as in this case. There can be a gradual improvement of the neuroretinal and RPE interface with a reconstitution of the ellipsoid zone and the ELM if you're not too late in the process. Also, you would like to reduce or prevent recurrences by addressing the primary underlying problem, which is the choroid. The problem with many studies that have been published thus far is that they were small and retrospective and highly variable in terms of their inclusion criteria and outcome measures. So be very careful when interpreting smaller and retrospective studies. The classification is still controversial. It has now been proposed to classify between simple and complex with different subtypes. In general, people have been classifying as acute versus chronic, but there is a whole gray area which I'm not going to dive into further. So what are the treatment options in chronic CSC? Well, many so-called treatments have been described, but here are the main ones. Photodynamic therapy, micropulse laser treatment, conventional laser coagulation, anti-VEGF treatment, and mineralocorticoid receptor antagonism. But there's a huge difference in efficacy of these treatments, and I'm going to discuss them with you in the next few minutes. Let's first go to the most important treatment, photodynamic therapy, the only really proven effective treatment for central serous choroidal. The idea behind it is that PDT really targets the choroid. When you use a large enough spot, you can really quiet down the leakage that can be seen on mid-phase ICGA of the choroid. And the choroid can become a more normal choroid after PDT treatment with less leakage and a more normalized choroidal thickness. In the past, full settings, like in the old AMD days, have been described to be safe and also effective, also at 4-year follow-up. But in recent years, half the dose or half the fluence or half the time has been shown to be probably equally effective and even safer than full settings PDT when it comes to the treatment of micropulse laser treatment. Is a treatment where it is thought that with pulses that have been subdivided in mini pulses with cooling down periods between these micropulses, that you would have a treatment effect on the RPE without having coagulation effects. This is an interesting treatment, but the efficacy has been disputed. I'm going to tell you a little bit more about that in the next few slides. And the treatment algorithms and which lasers you use is also a subject of controversy. So more data are needed to be sure that it really works. Conventional laser treatment can still be useful, especially when no PDT is available, for eccentric leaks where you hit the leakage point on FFA through the RPE, if it is a safe area, and then you get rid of the leakage and have a faster resolution of the subretinal fluid, although there are of course risks involved with this treatment in terms of CNV development on longer term follow-up, scotoma, and it's also the case that you don't want to treat too close to the macula. Also, you're not treating the primary abnormality in CSC, which is the choroid with this treatment. Anti-VEGF treatment has been tested for CSC, but has been found to be inferior to photodynamic therapy and other treatments. And it is only useful when there's also a neovascular component in the disease. Mineralocorticoid receptor antagonists such as eplerenone and spironolactone have also been proposed as a potential treatment in CSC. I'm going to discuss them later. PDT, half-dose PDT and micropulse laser treatment have been studied in a relatively large prospective randomized controlled trial, the PLACE trial by our group, European investigator-initiated trial, in which ICGA-guided PDT or micropulse laser treatment was performed. And it showed that with regard to a complete resolution of subretinal fluid, as well as with regard to functional improvement of microperimetry, that half-dose PDT was markedly more effective than micropulse laser treatment for chronic central serous chorioretinopathy, so both anatomically and functionally. Also, it didn't matter if it was focal or diffuse leakage on FFA. In both cases, PDT was more effective. And also, it was shown that if unsuccessful micropulse laser treatment was followed by PDT, there was a high rate of success of complete resolution, whereas this was not the case when patients did not respond to PDT and were then switched to micropulse laser. A very important additional randomized controlled trial was the Vichy trial, an investigator-initiated trial performed in the United Kingdom, in which oral eplerenone was compared to placebo. And it was found in chronic CSC that oral eplerenone did not do any better, also not after 12 months, than placebo. So the authors rightfully concluded that there was no place for eplerenone treatment in central serous chorioretinopathy. We found the same actually when we performed the Dutch prospective randomized controlled SPECTRA trial, in which we compared half-dose PDT to eplerenone treatment, and we found that PDT was much more efficacious than eplerenone treatment in terms of complete resolution of fluid, but also in terms of functional improvement on microperimetry. So we have 3 relatively large prospective randomized controlled trials showing that half-dose PDT is superior over micropulse laser and eplerenone, and that eplerenone is not better than placebo. These prospective trials are essential in a disease like CSC. If you want to read more about that, you could read this overview of treatment of CSC, evidence-based treatment. It is available open access in progress and retinal eye research, in which we also propose flowcharts on acute and chronic CSC. And this brings us to the question why PDT works so well at present and works best at present in CSC. Well, this is the case probably because it is a more direct and rapid treatment of the choroidal and RPE problem. It is most effective in relatively rapid and complete subretinal fluid resolution. And it also leads to less recurrences when you treat people with PDT. The important question that I often get is, what about the safety of PDT? Is it really safe also in the long term? And can you, for instance, treat the fovea? Well, we've treated many, many patients in the Netherlands already. So for me, it was a no-brainer that was the case, but you have to show it. And what we did is we looked at 57 patients from the PLACE and SPECTRA trial, the prospective trials, who had chronic CSC, and we looked at patients who received a single half-dose PDT treatment that also covered at least partially the fovea and achieved a complete resolution of fluid. And after 2 years of follow-up, we found that there was a marked improvement of the outer retinal structures, likewise for functional parameters, and none of the patients developed any atrophy of these structures or of the RPE on OCT and fundus autofluorescence. So yes, PDT in chronic CSC is safe and effective. So we can conclude that the current evidence strongly suggests that half-dose or half-fluence PDT should be the treatment of choice in chronic CSC. It is the most effective and it is safe. Observation may be the preferred approach in acute CSC because of its high tendency to resolve spontaneously, but consider treatment in selected cases, for instance, for professional reasons. And finally, I would like to tell you something about central serous chorioretinopathy that is complicated by CNV, which is relatively common in chronic CSC. And you can see, it can look like this, like a flat, irregular pigment epithelial attachment with mid-reflective material below it. And in those cases, the question is, how should you treat them? So it is relatively common, and patients also often have a polypoidal component. And it has been shown in several relatively large studies that there is a variable incomplete anti-VEGF response in CNVs and CSC. This may be due to the relative inactivity of the CNV, whereas the CSC background might be the primary or more important cause of subretinal fluid. So maybe, but this has to be proven in larger studies, primary PDT or a combination of PDT and anti-VEGF treatment may be the most valid treatment option in these cases, especially when there is also a polypoidal component. With that, I would like to thank you for your attention, and now we will go into the discussion. So that concludes the talks. And then we can quickly go to the discussion because we have received quite a lot of questions. And Elon, maybe you would like to open the ball with regard to the questions, because they have a very wide range of topics.
Yes. So in the first instance, we received a few questions on the experimental studies, Sekar. Maybe you can tell us once again, what gene do you think that's the most important in the pathogenesis of CSC now? And could you also elaborate a bit more on that gene and its implications?
Yeah, thank you, Elon, for the questions. Yeah, this is actually also very interesting to see that some of genes that pops up from the males and females that treated with the cortisol. One of the genes that we are really interested in is ZPTB16, is the most upregulated gene by the cortisol, and it is actually a massive transcriptional regulator. It can activate, it can repress, and it's ubiquitously expressed in other tissue as well. And another gene that is a second most upregulated is angiopoietin-like 4, and it's also implicated in a barrier regulation of endothelial cells. So that's also one of the genes that worth to study. And we need to, of course, to test those genes, we need the experimental model, a right experimental model to test whether it's involved or not.
Thank you, Sekar. Elon, was there another question on the experimental?
Yeah,
aspects?
there was one other question, and yeah, that's regarding the intrinsic differences between males and females. So based on your study, Sekar, there seem not to be those large differences between the male and female choroids. What could then be the origin of the disease?
Yeah, so that's actually the opposite what we found in the patients, right? And also the risk factor of the CSC. And the question is, we always expect that maybe androgen receptors, since it's really play a role in male, may play a role as well in the CSC, but we also forget to think about the estrogen and the progesterone receptors as they are also protective in the female. So maybe that's also the reason why that the female is less to have the CSC, and that's also something to work to discover.
Yeah, excellent. And we received one question, yeah, that's a bit of more on the diagnosis section. I can answer that question. So it was, do you check the serum cortisol levels for all CSC patients? We don't, but when there are other signs that could be indicative of a Cushing syndrome, so hypertension, fat pads, hirsutism, then we send these patients to the endocrinologist. So it's not a standard thing, but yeah, only when it's indicated. Yeah, Suzanne.
So if you see a case of suspected CSC, what is it that you do? Do you just look at the OCT, or do you immediately perform FA and ICGA, or do you also every time do an OCTA? What is it that you do from an imaging point of view, from a new case of CSC?
Yeah, so I think it's important to address the duration of complaints. So in a peripheral hospital, I would absolutely first do an OCT, try to find out if you think it's a typical acute CSC, maybe if there's any steroid use. You can actually wait for 6 to 8 weeks. And when there's persistence of retinal fluid, you would definitely need to perform additional imaging, which in my opinion includes FA, ICGA, and also OCTA, because a choroidal neovascularization occurs quite often in the CSC patients.
So for the viewers here that don't have ICGA and maybe not OCTA, what would you suggest them to do if they see a new case with CSC? Just wait and see for a while, or just immediately refer them to a center that has all the imaging available?
Yeah, it also depends a bit on the patient, because I could think when it is my eye that I would like to be referred to an academic medical center right away, because yeah, maybe also for acute CSC, the earlier you treat, the better your visual acuity can be on the longer term. But I think for most patients, it's okay to advise them just to wait for 3 months or 6 weeks to 3 months, and then see if it resolves spontaneously, also taking the verteporfin shortage into account at this point.
Yeah, so I had one more question, also maybe for Sekar. So there was a question from Manish Jain about why is there no difference in the risk factors that has thus far been found between men and women?
Sorry, I think I've already answered that.
Oh, good. Thanks. Thanks. I was going through the questions. Then I've got another question, Suzanne, maybe. There was one question that I found quite intriguing. So what about the possible role for vortex vein decompression, given that's an interesting one. I've got my opinions on that, but maybe you can give your view on that.
Oh, I don't think I have an immediate answer to that one. I think vortex veins are very interesting and there's a lot to learn. I'm not sure if it's necessarily vortex vein decompression that we should be looking at. Maybe the way, if you can change the way you say the veins are, I don't know the word that I'm looking for. Maybe
I can fill in.
Yes, please.
Yeah, so I've heard that before, vortex vein decompression, which makes sense given the ideas that have been now given about the pathogenesis, right? The venous overload, and Professor Cheung has very nicely shown that. But vortex vein decompression is quite invasive, and we have a good treatment, at least when there is Visiodine available. We're going to touch upon that soon now, which is PDT. So, and CSC is more than just venous overload. I'm convinced that it's more than that. So I think the risk is also too high.
Maybe in recurrent cases. But no, I wouldn't go there. But it's a very interesting, different way of looking on treatment for CSC. And like I said, I don't think that's the answer, but maybe we can change the way of drainage on the vortex veins, and that may actually be a treatment for CSC or CSC related diseases.
Yes, I agree. That brings us to the Visiodine shortage, which is it's the elephant in the room today, right? Because we're saying, well, PDT is the best treatment. It's the only really evidence-based treatment for CSC, but there is a Visiodine shortage. And the interesting and frustrating thing is that there is a huge difference between countries in terms of availability. So if there's no Visiodine available, well, the first thing you can try as a country is to try everything you can to get it through the firms that are representing it. But already in Europe, for instance, there's a big difference. In the Netherlands, where we work, there is a shortage, but it is available and it's also reimbursed, which we are very lucky with. But if it's not available, you can treat eccentric leaks, for instance, with conventional focal laser coagulation. Because micropulse laser and eplerenone have now been shown not to be effective, at least in the great majority of patients. It's not very harmful, so you could try it maybe, but there doesn't seem to be a good rationale for that based on the good studies. But focal laser treatment has been shown in old studies. It was actually from the pre-OST era to maybe be effective. But try your very best to get Visiodine available if you can. But it's rather mysterious why it's not available in some countries. It can have to do something with politics and price that countries pay for Visiodine. But it's very strange, and we're working on it to find out how this exactly works. What do you think, Suzanne? Do you have anything to add to that?
No, I don't have anything to add to that. What I wanted to discuss is one of the questions that were asked about if a patient has CSC, poor vision, and subretinal fluid is increasing. And I guess that from the Q&A that some of our colleagues are then, with a patient that's very demanding, maybe give an anti-VEGF injection, which I don't think there is a place for anti-VEGF in regular CSC because it's not a VEGF-driven disease. But how do you respond to a patient that is very demanding, but you cannot deliver? How do you discuss that with your patient?
Yeah, I think you should really tell them the truth so that the best treatment is actually not available or only very scarcely available, and that the possible alternatives are no alternatives at all, talking about spironolactone or eplerenone, and also micropulse laser treatment. Um, but then, yeah, so the one who posed that question, I must agree that in some of the patients there is a CNV, which is not always very clear, but maybe in those patients, when a patient is older, when there is a flat retinal pigment epithelium detachment with a mid to hyperreflective content, then you could try to see if there's any effect of that anti-VEGF injection, but then still you should really counsel that patient because every injection has got a risk. And in my opinion, also in those patients, it's not really proven that it will help.
Thank you, Elon. A very interesting question also in the chat is, what if the first PDT didn't work? Well, first of all, reevaluate the diagnosis. So think about the differential diagnostic possibilities. I think very important will be to do FFA and ICGA. For instance, I always use the Spectralis, which is a very high resolution. If you have it available, look at the FFA and ICGA, and there should be mid-phase hyperfluorescent areas on ICGA that are very typical of active choroidal dysfunction. So if you don't see another reason for the fluid, for instance, CNV or another diagnosis, have a look on FFA if there's still some focal leakage. If there is, there's a good rationale for another PDT treatment. If there isn't, and you have all the signs of PDT, so it's a chronic CSC, everything else has been excluded, and there's no focal leakage, then you're in trouble. Because in my experience, there's nothing actually that works. You could discuss with the patient to try some other stuff, but in my experience, nothing else works. And with regard to the question that is attached to that, there was a question, what about spironolactone as another mineralocorticoid receptor antagonist alternative for eplerenone? There are some problems with that. First of all, there are no good studies showing that that does work. And some small case reports are not helpful because there's, even in chronic CSC, there is a waxing and waning of fluid, and 30% of the placebo-treated patients in the Vichy trial actually had a spontaneous resolution after 1 year. So be careful with interpreting case reports. And the thing with spironolactone is also that it's less specific for the mineralocorticoid receptor, so it has more adverse effects. And quite some patients, male patients, can have gynecomastia, so breast formation, for example. So probably not wise to use that chronically, especially given the lack of evidence.
And Camiel, just going back to the PDT once again, what treatment settings do you use? So what is your treatment spot? And could you also elaborate a bit more on the safety in the first PDT, yes, and maybe also on repeated PDT?
Yeah, on repeated PDT, in my personal experience, but please fill in if you don't agree, it is also safe with repeated PDT, although less effective. So the first hit is the best. I use ICGA guided PDT, as we probably all do in the Netherlands, because you want to treat the choroid with PDT. And often these abnormalities, as Dr. Van Dijk has shown, are more extensive than on FFA. And you can include the fovea because, as I mentioned in my talk, it is very safe and effective. And there is no risk of choroidal infarction. We've treated thousands of patients in the Netherlands now without any cases of choroidal infarction using half dose. And I would use half dose because then you could split one vial between two patients if your country allows it. So that saves costs. And if the Visudyne is rare, you can use one vial for two patients. So that could be useful.
Camiel, is there a limit in number of PDTs you would do in one eye?
Well, in terms of safety, so I see some as you do, as we all do here in this panel, we see some really nasty chronic cases. I think you should try to treat early on in the disease if possible, but in these advanced diseases, we sometimes try to treat multiple times. But if the first PDT doesn't work and we have rethought the diagnosis, a second and a third PDT only works when there is still some focal leakage. I think it is quite safe in my experience, but not super useful. So yeah, that's a problem, I think.
How about in recurrences? So if you have a good effect from your PDT and then the patient returns a year later with recurrence of subretinal fluid, and that continues several times, like is there a limit of number of PDTs you would perform, or?
Well, I've never performed more than 3 PDTs in one eye because I don't think it's useful. But if there's a recurrence, do the FFA ICGA, and if there's focal leakage, it may very well help because it quiets down the choroid. But the long-term outcome of a successful single PDT is quite good, so it reduces the risk of recurrences. One question that I wanted to address, a very interesting question, I think, is how do you treat when you don't have PDT? You do focal laser with a conventional coagulation. So you can use only one or a few spots to try to hit the exact spot based on the focal leak on FFA, if it's not too diffuse. And if you want to check if it has worked well, you can just do the follow-up after a few months. But I talked to a colleague who had a very interesting approach if you can do that. So this colleague, I think it was he did a very soon after the treatment in the same session. So at the end of the day, he did another FFA, and if the leak stopped, he knew it was successful. So you could even consider that. I've never done that, but yeah. So hit it on the spot, not too centrally, and don't use too many coagulations because of the scotoma and CNV risk, I think. Do you agree, Elon and Suzanne?
I think it's very interesting, but I think the papers from Spade and Freund have shown that initially after PDT, you get an increase of subretinal fluid, right? So there must be leakage after PDT. That is probably even like...
No, I mean focal laser.
Oh, with focal laser.
Yeah, so with focal laser. So with the PDT, no, I'm talking about focal laser. How do you treat that? So I would just treat the leak with not more than a few spots. You could even redo the FFA some hours after treatment to see if the leak has stopped. But I've never done that.
Quite an intense day for the patient, but it could work.
But just wait and see if it helps.
Yeah. And then maybe as a last question, as we are getting out of time, in terms of having a look at the future. So one of the questions is, do we have a prognosis on the verteporfin shortage? So both you, Suzanne, and Camiel, you're in the PDT committee in the Netherlands. Could you maybe provide us some hope for the future, or is it just like not so much hope?
That committee.
Well, I'm pretty convinced that at one point we will have access to Visudyne again, but I'm not really sure when that will be. So we've been discussing with the say the provider for Europe. There's only one factory in the world that actually prepares the Visudyne, and so it's distributed over the world. And there's one, let's say, like pharmaceutical company that's distributing it through Europe. And well, let's say that the perspective that we were given, they have never met it, and it's changed again and again and again. So now we are promised that it will be available by the end of this year, and I hope that is right, but I'm doubtful.
Yeah, so if anyone, so we have hundreds of viewers tonight, and we have maybe more who will watch it later. If anyone has access to starting a second factory of Visudyne and wants to make a nice amount of money, please start another factory and make Visudyne, because it will be very helpful in solving this problem.
And all of us would like to invest, I think.
Yeah. I would like to thank my co-speakers very much for your time and your wonderful input. Thanks to all the people who've listened to this webinar or going to listen to the webinar for your attention. And it was a pleasure to do this, and maybe we'll meet again in the future for another update. In the meantime, Sekar, Dr. Galuh, is trying to find new treatments, because we want more than just PDT to be effective. And we'll have a nice evening or day, afternoon, and all the best.